Your Royal Highness, Your Excellencies, ladies and gentlemen, thank you for having Médecins Sans Frontières, MSF, Doctors Without Borders, here today. What is the threat of emerging infectious diseases? It is unfolding as we speak, but it doesn't hit the headlines. It is airborne, it's drug-resistant, and it emerged centuries ago. Next slide. In 2016, WHO estimated that there were nearly 500,000 new cases of multi-drug-resistant TB, with only about a quarter detected and reported, and only 54% successfully treated. Why not place tuberculosis as the public health emergency? Of the 10 million total deaths that might be associated with drug resistance per year by 2050, around a quarter will be because of drug-resistant TB. What to do when TB, a curable disease, is today the world's leading infectious diseases killer? Next slide. Here's the deal, how we see it. It's about the who and the what, the where and the when, the why and the how. Next slide. Whose health is at threat? Not everyone runs the same risk. We know of the unequal distribution of emerging infectious disease burden, public health threats, and vulnerability to them. The populations at higher risk are living in regions of armed conflict, of mass displacement, in areas of great instability and structural poverty. They are those without access to medical care, the invisible, the neglected ones. These people must be acknowledged and must be part of the equation for the response to infectious diseases to work. You are healthy because your neighbor is healthy. It is interconnected. The communities who are most likely to bear emerging diseases are to be prioritized, to put focus on, to be cared for. Next slide, please. What are the threats? Yellow fever, cholera, measles, meningitis, diphtheria, TB. The real killers today are the epidemics we deal with on a daily basis, not only the ones under the spotlight, but the boring because so frequent ones. In the past months, MSF teams responded to an epidemic of diphtheria in the Rohingya refugee camps in Bangladesh following an outbreak of measles. In December, diphtheria also raised its head in Yemen at the back end of one of the largest cholera epidemics we know of, with over 1 million suspected cholera cases across the country. 2017 also saw the largest meningitis C outbreak in Nigeria in the past 9 years, and an outbreak of hepatitis E in the Difa region of Niger, where 250,000 people displaced by violence live in overcrowded conditions. We also see an increase in resistant strains of diseases. Antimicrobial resistance is growing in the setting where we operate, but we are lagging behind to measure and document the scale of a problem. The problem. In MSF's reconstructive surgical program in Amman, Jordan, very high levels of resistance were found among bacteria causing chronic osteomyelitis in patients coming from Iraq, Yemen, and Syria. With Mahidol University in this audience, you're very much aware of the increased resistance to first-line treatment for falciparum malaria, confirmed in 5 countries of the greater Mekong subregion. We are also seeing a wave of drug-resistant HIV infection, people not anymore living with HIV, but dying from AIDS. In some MSF inpatient facilities, 70% of hospital admissions are advanced HIV patients in clinical failure. At the Centre Hospitalier Cabinda in Kinshasa, where our teams work, 2/3 of HIV patients are admitted with an AIDS condition. The mortality rate in the inpatient department is extremely high, 37 inpatients needing hospital admission, of which 1/3 die within the first 48 hours. A WHO 2017 report highlights increasing pretreatment HIV drug resistance in low and middle-income countries, particularly in Southern and Eastern Africa. And of course, TB, the world's major drug-resistant epidemic and one of the biggest drivers of the AMR threat. Next slide. So where is the risk? Epidemics can place the strongest health systems under strain, but the risk is highest in a specific context, such as an armed conflict and massive displacement. Go to the next slide, please. It is about populations who are stripped of access to basic healthcare, and we are not talking about CT scan or even fancy third-generation cephalosporins. It is about having population bare naked in front of viruses and bugs. Take diphtheria amongst the Rohingya who fled to Bangladesh, and the population caught up in a deadly war in Yemen as the perfect storm, a vaccine-preventable disease of the past. Diphtheria has seen a resurgence in war zones and in communities fleeing persecution. There's a lack of rapid diagnostic tests, a need for a long and cumbersome antibiotic treatment difficult to adhere to, and a scarcity of horse serum antitoxin to treat severe cases at the expense of extremely serious side effects. The resurgence of diphtheria in the refugee camps in Bangladesh is a testimony to the Rohingyas' exclusion from healthcare back in Myanmar, where the majority of them were not vaccinated against any diseases, as they had very limited access to routine healthcare, including vaccinations. With a global shortage of less than 5,000 vials of diphtheria antitoxin and very limited quantities available in these countries, there might be not enough medication to treat all of the children in front of you who need it. Next slide. When do we react? Now. React now. We puzzle over global simulation exercise on hypothetical devastating pandemics and potential patients. While we look forward to mitigating further risk, we should be addressing current needs and tackling the real-life obstacles of epidemic response in precarious settings, the real-time epidemics going on in real conditions with real lives at threat. Time's up for them. Next slide. The why and the how. We were all late for the Ebola epidemic in 2014. How far are we better off today? How do we do better next time? We have to think local, think community, think people. Focus on affected populations and remain patient-centered. Community ownership and its empowerment has to happen. It is the game changer when addressing emerging infectious disease. An epidemic response that only looks at the disease but forgets the people will lose the people. Responding to patient needs is the best payoff for affected populations and for the global health security. It's a win-win situation. Strong leadership and political courage is needed for wealthy countries to match the reality of emerging infectious diseases, the threat it represents to the most exposed and vulnerable populations with no choice. These affected populations need not to be treated as a threat, but cared for. Applying exclusively the security lens does not succeed to engage with the communities. Health security should be a commitment to secure health for all, as it's been said, without discrimination, not one at the expense of the others. We need to transform the threat and fear into an opportunity. Next slide. So what do we know already? The WHO are populations affected by conflict, mass displacement, and exclusion from access to healthcare. The what is everyday's epidemics, the serial killer of every day, measles, cholera, meningitis, TB. The where in a specific context. Why? Because Ebola was a very humbling experience for all of us. Our biggest responsibility is to learn from it and to put it into practice. How? By responding to existing emerging infectious diseases today. Let me award on Ebola new experimental vaccines stoked in a cold chain of big pharma at below 60 degrees. Not that handy for Ebola contacts in Congo. A vaccine, a diagnostic tool, or a treatment is only useful if it gets to the people. The 3A should be respected: accessible, adaptable, affordable. A wealth of powerful will, experience, and brains are here in this audience. It's time to translate language into action. For making all of us healthier depends on caring for those most vulnerable among us. By doing so in real time, we'll get together fit for purpose. Thank you very much for your attention.